puberty. So, description of disease or complication. Precocious puberty, also known as early puberty, is when a child's body starts to go through the change into an adult body too soon. So, etiology or cause of this condition. The cause of precocious puberty often can't be found. Rarely, certain conditions such as infections, hormone disorders, tumors, brain abnormalities, or injuries may cause this condition. So let us now talk about the types of precocious puberty. So first we have the central precocious puberty, which is more common. It's just like a normal puberty, but it happens early. This happens when the pituitary gland starts making hormones called gonadotropins, and these hormones cause the testicles or ovaries to make other hormones, testosterone or estrogen. These sex hormones cause the changes of puberty, like breast development in girls. In rare cases, central precocious puberty may be caused by a tumor in the brain or spinal cord, a defect in the brain present at birth, radiation to the brain, injury to the brain, Makian-Albright syndrome, which is a rare genetic disease that affects bones and skin color and causes hormonal problems. Then we have the congenital adrenal hyperplasia, which is a group of genetic disorders involving abnormal hormone production by the adrenal glands, and hypothyroidism, which is a condition in which the thyroid gland doesn't produce enough hormones. Then we have the peripheral precocious puberty or precocious pseudopuberty. It is less common. It happens when hormones estrogen and testosterone trigger the symptoms, but the brain and pituitary gland are not involved. It's usually a local problem with the ovaries, testicles, adrenal gland, or a severely underactive thyroid gland. In both girls and boys, the following may lead to peripheral precocious puberty: a tumor in the adrenal glands, Makian-Albright syndrome, exposure to external sources of estrogen or testosterone, such as creams or ointments. In girls, peripheral precocious puberty may also be associated with ovarian cysts, ovarian tumors, and in boys, this condition may also be caused by a tumor in the cells that make the sperm or in the cells that make testosterone, and a rare disorder called gonadotropin independent familial sexual precocity, which is caused by a defect in the gene and can result in an early production of testosterone in boys, usually between ages 1 and 4. Disease process. To help understand what causes precocious puberty in some children, it's helpful to know what causes puberty to begin. The brain starts the process with the production of a hormone called gonadotropin releasing hormone, and when this hormone reaches the pituitary gland, which is a small bean-shaped gland at the base of your brain, it leads to the production of more hormones in the ovaries for females, estrogen, and the testicles for males, which is testosterone. Estrogen is involved in the growth and development of female sexual characteristics, and testosterone is responsible for the growth and development of male sexual characteristics. So, risk assessment. We should review the child's and family medical history, run blood tests to measure hormone levels, and physical examination for us to notice physical changes in the child's body. So here are the signs and symptoms of this condition. So for girls, run blood tests to measure hormone levels, menstruation, which typically not until 2 to 3 years after the earlier symptom starts. For boys, testicles, penis, and scrotum starts to grow, and voice deepening. This is usually a late sign of puberty. And for both boys and girls, rapid height growth, acne, and adult body odor. So diagnostic tests for this condition. First, we have the magnetic resonance imaging or MRI. A brain MRI is usually done for children who have central precocious puberty to see if any brain abnormalities are causing the early start of puberty. Then we have the thyroid testing. The doctor may also test your child's thyroid if he or she shows any signs of slow thyroid function, such as fatigue, sluggishness, increased sensitivity to cold, constipation, a drop in school performance, or pale, dry skin. X ray, which is used for x-ray their hands and wrists to look at bone age. This tells them if the bones are growing too quickly. Then we have the gonadotropin releasing hormone stimulation test. Child's hormone responds over time through a series of blood samples. If other hormones rise, that's a sign of central precocious puberty. If hormone level stays the same, that is a sign of peripheral precocious puberty. So we have three nursing diagnoses for this condition. First, we have the disturbed thought processes related to mood swings, irritability, and depression. Disturbed body image related to altered physical appearance evidenced by precocious puberty, and risk for disproportionate growth related to congenital disorder. So for our first nursing diagnosis, due to changes brought by early puberty, patients with this condition get rid of experiencing mood swings and other emotional changes. For our second nursing diagnosis, this condition results to alteration of one's physical appearance at an early age. They may notice there are changes in the body that should be evident once puberty stage. Then for a third nursing diagnosis, its rationale is to be aware of this condition and how it affects the growth of the patient. Then we have our management for this condition. Let us start with our nursing intervention. First, monitor growth to assess any changes that should not yet be showing, basing on the patient's age. Provide psychological support for patient not to feel down and hopeless of the condition. Give teaching about normal growth and development for knowledge of this condition and how it may affect the patient. And for our medical intervention, we have the GnRH analog therapy. They are agonists of the GnRH receptor and work by increasing or decreasing the release of gonadotropins and the production of sex hormones by the gonads. When used to suppress gonadotropin release, GnRH agonists can lower sex hormones levels by 95% in both sexes. Then for our pharmacologic interventions, we have the androgen antagonists, which is used to treat an assortment of androgen-dependent condition. Testolactone, it works by blocking the production of estrogen, which helps prevent the growth of breast cancers that are activated by estrogen. It may also prevent tumor cells from being activated by other hormones. Then we have the medroxyprogesterone acetate, which is used to treat amenorrhea and abnormal uterine bleeding. It is also used to prevent endometrial hyperplasia in women who are taking conjugated estrogens. This medicine is a progestin hormone. Then we have our surgical intervention. We have the Hystrulin implant or Vantas. The doctor puts it under the skin of the inside part of the upper arm. It also delays development but doesn't require monthly shots. The implant lasts for a year. Tumor removal. This is done if condition is caused by tumor in CNS or ovary to prevent condition for worsening or prevent tumor from growing. And we have our pathophysiology for the condition. For our nursing care plan, needs, problems, or cues, we have the physiologic deficit, which is disturbed body image, objective cues, alteration in body structure, hiding of body part, avoids looking or touching one's body. Subjective cues, I am afraid people will think I am not normal because of my physical appearance as verbalized by the patient. For our nursing diagnosis, we have disturbed body image related to altered physical appearance, evidenced by precocious puberty. For our scientific basis, precocious puberty, or more precisely society's reaction to early maturation, has the potential to harm the self-esteem and body image of girls and boys alike. Fortunately, researchers in the social sciences and medicine are helping to raise awareness of both the causes and the physical, emotional, and social consequences of precocious puberty. For our objectives of care, for our general objective, we have after a week of holistic nurse patient interaction, the client will be able to verbalize an understanding of body changes. For our specific objectives, after 8 hours of SN patient interaction, the patient will be able to verbalize the acceptance of self in a situation and acknowledge the self as an individual who is responsible for one's own self. For a nursing intervention, we have it measures to promote understanding on one's body change. Independent nursing intervention, we have acknowledge and accept expression of feelings of frustration, dependency, anger, grief, and hostility, note withdrawn behavior, and use of denial. Acceptance of these feelings as a normal response to what has occurred facilitates resolution. It is not helpful or possible to push patient before ready to deal with condition or situation. Then we have support verbalization of positive or negative feelings about the actual or perceived loss. It is worthwhile to encourage the patient to separate feelings about changes in body structure or functioning from feelings about self worth. Expression of feelings can enhance the patient's coping strategies. Then we have assist the patient in incorporating actual changes into ADLs, social life, interpersonal relationships, and occupational activities. The more noticeable the change in body structure or function, the more anxious the patient may have about the response of others to the change. Opportunities for positive feedback and success in social situations may hasten adaptation. We have discussed with patient about the normalcy of body change, body image disturbance, and the grief process. The patient experiencing a body change needs new information to support cognitive appraisal of the change. Teach the patient adaptive behavior. Adaptive behaviors help the patient compensate for actual change body structure and function. For our dependent interventions, we have administer medication as ordered by physician. To administer medication and administer these medications to enhance patient's condition. Assess for side effects of the medication. This is to be aware of the severe allergic reaction or the adverse effect of medication to the patient. Then we have assess for effectivity of medication to patient's condition. This is to evaluate the effectivity of the medication to the patients if there were changes that are noticeable. For interdependent intervention, we have refer the patient and caregivers to support groups composed of individuals with similar alterations. Lay people in similar situations offer a different type of support which is perceived as helpful to the patient. Refer to physical and occupational therapy, vocational counselor, psychiatric counseling. So moving on, let us talk about the disorders of adrenal function. And again, once again, this is Ms. Rosal and I will be talking about Cushing's syndrome. Definition. Cushing syndrome, also sometimes called Cushing's syndrome, is a disorder with physical and mental changes that result from having too much cortisol in the blood for a long period of time. Cortisol is a steroid hormone produced by the adrenal glands located above the kidneys. In normal counts, cortisol helps the body through responding to stress, maintaining blood pressure and cardiovascular function, keeping the immune system in check, convert fat, carbohydrates, and proteins into energy. Etiology or cause of the condition. Cushing disease is caused by a tumor or excess growth of the pituitary gland. The pituitary gland is located just below the base of the brain. A type of pituitary tumor called an adenoma is the most common cause. An adenoma is a benign tumor. Then we have the types of Cushing syndrome. So first we have the exogenous. Exogenous Cushing syndrome is due to people taking cortisol-like medications such as prednisone. These drugs are used to treat inflammatory disorders such as asthma, and rheumatoid arthritis. They also suppress the immune system after an organ transplant. So, this type of Cushing syndrome is temporary and goes away after the patient has finished taking the cortisol like medications. Then, next, we have the endogenous Cushing syndrome. It is in which the adrenal glands produce too much cortisol and is uncommon. It usually comes on slowly and can be difficult to diagnose. So, this type of Cushing syndrome is most often caused by hormone secreting tumors of the adrenal glands or the pituitary, which is a gland located at the base of the brain. In the adrenal glands, the tumor produces too much cortisol. In the pituitary, the tumor produces too much ACTH, the hormone that tells the adrenal glands to make cortisol. When the Cushing syndrome is due to a pituitary tumor, it is called Cushing disease. Disease process. Cortisol helps regulate your blood pressure, reduces inflammation, and keeps your heart and blood vessels functioning normally. Cortisol helps your body respond to stress. It also regulates the way you convert proteins, carbohydrate, and fats in your diet into usable energy. However, when the level of cortisol is too high in your body, you may develop this condition. So, risk assessment. Review child's or family's medical history, run blood tests to measure hormone levels, physical examination, look for signs like buffalo hump and stretch marks and bruises. So, signs and symptoms of this condition: weight gain, especially in the upper body, as shown in the picture, rounded face and extra fat on the upper back and above the collarbones, high blood sugar, high blood pressure, thin bones, muscle loss and weakness, thin fragile skin that bruises easily, purple red stretch marks, depression and difficulties thinking clearly, and too much facial hair in women. So, diagnostic tests for this condition. First, we have the urine and blood tests. These tests measure hormone levels in your urine and blood and show whether your body is producing excessive cortisol. For the urine tests, you may be asked to collect your urine over a 24-hour period. Both the urine and blood samples will be sent to a laboratory to be analyzed for cortisol levels. Then we have the saliva test. Cortisol levels normally rise and fall throughout the day. In people without Cushing syndrome, levels of cortisol drop significantly in the evening. By analyzing cortisol levels from a small sample of saliva collected at night, doctors can see if cortisol levels are too high, suggesting a diagnosis of Cushing syndrome. Then we have the imaging tests, the computerized tomography scans, or magnetic resonance imaging scans. These can provide images of your pituitary and adrenal glands to detect abnormalities such as tumors. Then we have the petrosal sinus sampling. This test can help determine whether the cause of endogenous Cushing syndrome is rooted in the pituitary or somewhere else. For the test, blood samples are taken from the petrosal sinuses, veins that drain the pituitary gland. And lastly, we have the low dose dexamethasone suppression test. It measures the response of the adrenal glands to ACTH and has been widely utilized for 4 decades. It involves taking a small dose of a cortisol-like drug, dexamethasone, at 11 p.m., then having blood drawn to screen for cortisol the following morning. In patients without Cushing syndrome, the morning level of cortisol is typically very low, indicating that ACTH secretion was suppressed by the evening dose of dexamethasone. In patients with Cushing syndrome, the morning cortisol level will be high. It is evident that normal patients will suppress their cortisol in a very low level, whereas those suffering from Cushing syndrome will not. For our nursing diagnosis, we have disturbed thought processes related to chemical changes in the brain from high cortisol evidenced by mood swings, irritability, and anxiety, disturbed body image related to altered physical appearance, impaired sexual functioning and decreased activity level evidenced by Cushing syndrome, deficient knowledge evidenced by lack of experience with Cushing's disease related to verbalized misconceptions. For our first nursing diagnosis, this is to raise awareness how this condition could greatly affect patient's psychological state. For our second nursing diagnosis, it provides awareness of the changes or effect of the condition to the patient's physical aspect and functioning. And for the third, this is to provide knowledge, to give a heads up on how lack of knowledge could result to misconceptions of the condition. Let us talk about the different management of the condition. First, we have our nursing intervention, monitor vital signs, especially BP and HR, to have a background of how the patient is doing and to know overall function. Monitor blood glucose levels and assess tools for blood because diabetes, mellitus, and peptic ulcer are common problems. This is to ensure that there is no increase of these levels, for these will result to complications. Assess fluid and electrolyte status by monitoring laboratory values and daily weight to know patient's nutritional status and to know if there is a risk for deficiency. Explain to the patient and family the cause of emotional instability and help them cope with mood swings, irritability, and depression. This is for them to have knowledge about patient's condition and to be aware of the psychological changes this will bring. For our medical intervention, we have the pituitary irradiation, patients with pituitary-dependent Cushing syndrome with adrenal hyperplasia and severe Cushingnoid syndrome may require pituitary irradiation. Radiotherapy. Radiotherapy is an effective second-line treatment in patients with Cushing's disease not cured by surgery. Remission of hypercortisolism occurs in roughly 50% of irradiated patients, but it takes some time, usually 2 to 3 years, independently of the technique used. For our pharmacologic interventions, we have adrenal enzyme inhibitors, metarapone, aminoglutamide, metotane, and ketoconazole. And these are used to reduce hyperadrenalism of the syndrome, which is caused by the ectopic ACTH secretion by a tumor that cannot be eradicated. Then we have the cortisol therapy. Cortisol therapy is essential during and after surgery to help patient tolerate the physiologic stress imposed by the removal of pituitary or adrenals. Then for our surgical interventions, we have the transsphenoidal hypopexectomy, which is the surgical removal of the tumor by transsphenoidal hypophyseectomy, is a treatment of choice if Cushing syndrome is caused by pituitary tumors that has an 80% success rate. And then we have the adrenalectomy. Adrenalectomy is the treatment of choice in patients with primary adrenal hypertrophy. So this is our pathophysiology for the condition. For our nursing care plan, we have the needs, problems, cues, psychological deficit, disturbed thought process, objective cues, irritability, mood swings, forgetfulness, feeling of anxiety, subjective cues, I easily get irritated from small things. I am also very moody, as what my friends told me, as verbalized by the patient. Nursing diagnosis, disturbed thought processes related to chemical changes in the brain from high cortisol evidenced by mood swings, irritability, and anxiety. Under our scientific basis, common thinking associates the hormone cortisol with negative mood states. Cortisol levels rise during stress, and thus cortisol is sometimes found to be associated with negative effect. Also, individuals with excessive cortisol secretion, like Cushing syndrome, often have depressed mood, which normalizes when their elevated cortisol is treated. For our objectives of care, under our general objective, we have, after a week of holistic nurse-patient interaction, the client will be able to exhibit normal thought process and improve mentation. Under our specific nursing, under our specific objective, after 8 hours of student nurse patient interaction, the patient will be able to appropriately interact and cooperate with staff and peers in the therapeutic community setting. For our nursing interventions, it measures to improve thought process. Independent intervention explain to patients and family the cause of emotional instability. High cortisol levels can be experienced by the body as anxiety and insomnia is very common in clients on steroids and with high cortisol levels. Encourage patients to discuss feelings and concerns. This will assist the client in verbalizing concerns and provides the opportunity to deal with of the patient. Provide a positive and caring environment for the client. The depressing effect of having serious and impairing illness may also contribute to depression. Repeat instructions as necessary using clear, simple language and short sentences. Cushing's disease can affect a client's concentration and memory, so we should also be patient and clear as much as possible in giving out instructions. Plan rest periods throughout the day and promote a relaxing, quiet environment for rest and sleep. Rest and sleep will give the patient strength and relaxation as well. Under our dependent intervention, we have administer medications as indicated. These medications are used to lower high cortisol levels due to tumors and may be helpful relieving some of the psychiatric symptoms associated with the high cortisol state. Observe for side effects of medication to be aware if patient is sensitive to medication given. Evaluate effectiveness of medication to know the effectivity of medication in patient's condition. For our interdependent intervention, we have assist the client in psychotherapy. Psychotherapy can help with depression, mood, and anxiety which are caused by Cushing's disease. Refer patient to group counseling or support groups for patient to feel support and hopeful. After a week of student nurse patient hyperplasia. Definition: congenital adrenal hyperplasia is an inherited disorder that results in low levels of cortisol and high levels of male hormones, causing development of male characteristics in females and early puberty in both boys and girls. Congenital adrenal hyperplasia refers to a group of genetic disorders that affect the adrenal glands, a pair of walnut-sized organs above the kidneys. The adrenal glands produce important hormones including cortisol, which regulates the body's response to illness or stress, mineralocorticoids such as aldosterone, which regulates sodium and potassium levels, androgens such as testosterone, which are male sex hormones. Etiology or cause of the condition. Congenital adrenal hyperplasia results from mutations in the gene that codes for one of several enzymes responsible for making steroid hormones in the adrenal glands. The most common enzyme to be affected is 21-hydroxylase, which is a key regulator in the synthesis of the stress hormone cortisol. In about 2/3 of affected individuals, the enzyme defect in the adrenal may also affect the production of the hormone aldosterone, which is responsible for retaining salt in the body. Now let us talk about the types of CAH. First, we have the classic CAH. This form is rarer and usually detected in infancy. Approximately 2/3 of people who have classic CAH have what's known as the salt-losing form, while 1/3 have what's referred to as the simple virilizing form. So, female infants who have classic CAH may have a condition known as ambiguous genitalia, in which the clitoris is enlarged or the genitals look more like those of male child. Male infants who have classic CAH have normal appearing genitals. Both male and female infants may be seriously affected by a lack of cortisol, aldosterone, and or both. This is known as an adrenal crisis and it can be life-threatening. The salt-losing form and simple virilizing form of classic CAH cause children's bodies to produce an insufficient amount of cortisol. These children can have problems maintaining normal blood pressure, normal blood sugar, and energy levels, and more vulnerable to stress. An excess of the male sex hormones can result in short height and early puberty for both boys and girls. For non-classic CAH, this form is milder and more common and may not become evident until childhood or early adulthood. Often there are no symptoms, and teenage and adult females who have non-classic CAH may have normal appearing genitals at birth, but later in life they may have experienced irregular or absent menstrual periods, masculine characteristics such as facial hair, excessive body hair, and a deepening voice, and severe acne. For the disease process, in patients with congenital adrenal hyperplasia, the body recognizes the lack of cortisol and therefore tries to stimulate the adrenal glands to try to produce sufficient levels. However, because there is an enzyme defect, the adrenal glands cannot produce cortisol and instead produces excess amounts of precursor steroids. For a risk assessment, we have prenatal ultrasound scan before baby is born, physical examination, family history, gene testing, amniocentesis. It is a procedure which involves using a needle to withdraw a simple sample of amniotic fluid from the womb and then examining the cells, then the chorionic villus sampling. This test involves withdrawing cells from the placenta for examination. Signs and symptoms of this condition is dehydration, poor feeding, diarrhea, vomiting, heart rhythm problems, low blood pressure, very low sodium levels, and low blood glucose. Signs and symptoms of these conditions with newborns includes vomiting, dehydration, and failure to gain weight. Babies with milder forms of CAH may have no symptoms. Older kids and teens with mild or moderate CAH may grow taller than average in early childhood and stop growing sooner than peers. Has a larger than average clitoris for girls and not have these changes expected with puberty or have them earlier or later than peers. So diagnostic tests for these conditions includes newborn screening, blood tests to check levels of adrenal hormones, blood chemistry to check sodium and high potassium levels in children with salt-losing types of CAH, and x-rays to see how rapidly the bones mature. For our nursing diagnosis for this condition, we have risk for disproportionate growth related to congenital disorder, fluid volume deficit related to endocrine dysfunction, evidenced by decreased blood pressure, disturbed body image related to altered physical appearance, impaired sexual functioning, and decreased activity level evidenced by condition. For our management for this condition, for our nursing intervention, we have assessed newborn girls for abnormal congenital or genital characteristics such as fused labia, enlarged clitoris, or abnormal location of urethral opening. This is done to find out abnormalities in a newborn's physical appearance so treatment will be planned. Assess newborn boys with unexplained dehydration and low sodium levels for adrenal insufficiency. Monitor renin levels closely to pay attention whether there will be a rise of blood pressure. Monitor blood pressure closely if receiving mineralocorticoid replacement therapy. This is to prevent blood pressure from rising beyond normal. For our medical management, we have hormone replacement. This can help balance estrogen and progesterone levels during or near menopause. There are also many other reasons why a doctor might prescribe supplementary sex hormones, also known as menopausal hormone therapy. HRT can help relieve sweating, hot flashes, and other symptoms of menopause. For our pharmacologic intervention, we have the hydrocortisone, which replaces the cortisol deficiency and prevents low blood sugars and low blood pressure. It can help prevent the effects on growth and puberty that untreated CAH causes. Then fludrocortisone to maintain body salt balance. Some infants may also have to take salt supplements by mouth. For our surgical management, this is considered to correct the genitals' appearance and function to improve the appearance and functioning of the genitalia. So this is our pathophysiology for the condition. For our NCP of for this condition, needs, problems, and cues: physiologic deficit, fluid volume deficit. Objective cues: dehydration, headache, dry lips, sweating, nausea, vomiting, decreased BP 60/90 mmHg. Subjective cues: I feel weak and dehydrated, dali rasad ko uhawon, as verbalized by the patient. Fluid volume deficit related to endocrine dysfunction evidenced by dehydration. For a nursing diagnosis, scientific basis: fluid imbalances on both ends of the spectrum may be a manifestation of poor kidney health. Edema, which occurs when the body retains too much fluid, commonly causes swelling and pain in the face, arms, legs, hands, and feet. Dehydration, which happens when the body loses more fluids than it consumes, can cause a range of symptoms including thirst, weakness, lightheadedness, fainting, and decrease in urine output or increase in its concentration. For our general objectives, after a week of holistic nurse-patient interaction, the patient will be able to demonstrate lifestyle changes to avoid progression of dehydration. Specific objective: after 8 hours of SN-patient interaction, the patient will be able to verbalize awareness of causative factors and behaviors essential to correct fluid deficit and explains measures that can be taken to treat or prevent fluid volume loss. For our nursing intervention, it measures to improve fluid volume. For independent intervention, monitor and document vital signs, especially BP and HR. Decrease in circulating blood volume can cause hypotension and tachycardia. Assess skin turgor or oral mucous membranes for signs of dehydration. This can be detected through the skin. Urge the patient to drink prescribed amount of fluid. Oral fluid replacement is indicated for mild fluid deficit and is a cost-effective method for replacement treatment. Older patients have a decreased. And for our nursing intervention, again, we have emphasized importance of oral hygiene. Fluid deficit can cause a dry, sticky mouth. Attention to mouth care promotes interest in drinking and reduces discomfort of dry mucous membranes. Provide comfortable environment by covering patient with light sheets. Drop situations where patient can express overheating to prevent further fluid loss. For our dependent nursing intervention, we have administer parenteral fluids as indicated. Fluids are necessary to maintain hydration status. Determination of the type and amount of fluid is to be replaced, and infusion rates will vary depending on clinical status. Observe for side effects of medication. This is to be aware if patient is sensitive to medication given. Evaluate effectiveness of medication to know effectivity of medication in patient's condition. For our interdependent interventions, we have refer patient to nutritionist or dietitian for proper nutrition and diet plan. Teach family members how to monitor output when they are at home. Instruct them to monitor both intake and output. An accurate measure of fluid intake and output is important indicator of patient's fluid status. For our evaluation,